morning, everyone. I'm really excited to share about our journey, especially in one domain of tuberculosis, actually. So just, oh, is it better now? Okay, perfect, thank you. So just to give an overview about my organization, I work at IDIA Global, which is one of the organizations funded by our donors who are businessmen in the US. So they put in their family foundation money to like our organization and with our sister organizations who are working in health, WASH, and other public health service related companies. So my organization, when I was in India, Indian entity, it was Vadvan Institute of Artificial Intelligence, where we develop AI solutions for social sector, especially in healthcare, agriculture, and education. And our aim was to build AI solutions for the bottom 95% of the people, which is basically developing AI solutions in low resource constrained settings, actually, like developing offline models, models that could work in very basic devices like basic smartphones and other things, actually. So we started our journey back in 2018. We were a team of around 20 people. Currently, we are a team of around 350 people back in India, where we are ML scientists, engineers, product managers, and subject matter experts in public policy, agriculturalists, epidemiologists working in different domains. And in 2025, we started the global entity where we want to take the work which we did in India to the other parts of the world. So that's where I transitioned from the Indian entity to the new global entity. And I'm based out of Nairobi for last 3.5 months. So today I want to share about the work which we did in the tuberculosis portfolio back in India. Tuberculosis is one of our oldest portfolio back in India. We came in as a official AI partners for the Central TB Division, which is a division under the Ministry of Health and Family Affairs of India, which manages the TB prevention program in India. So it's very important, as Doctor was saying, the implementation part of any digital intervention is very, very important, actually. So although I'm just going to share 4 interesting use cases in TB, I would say that these are the 4 ones we were able to successfully deploy. We had around 12 different use cases, out of which 8 were not feasible to be deployed in the field. So it is very important to learn from what it is and understand from the field, actually. So user experience and field testing is very, very important before taking your solution for scale. So just to give an overview about TB, I'm not a medical doctor, but just giving an overview about TB. TB is an infectious disease which is airborne, actually. Just for some facts, 1/3 of the world population have dormant TB, actually. They can get TB at any point of time if their immune system is compromised, actually. And it's not a one single problem. TB needs to be solved in multiple stages, actually. People don't get diagnosed at the right time, actually. There are a lot of asymptomatic and partially symptomatic cases, actually. And a lot of people miss out on treatments, actually, because the drugs which is used for TB has a lot of adverse drug reaction, actually, side effects because of which people tend to stop their medications. So it's very important that they take their medications throughout their course of treatment. Otherwise, the normal TB patient would turn into a drug-resistant TB case, which is even more hard to treat, actually. And also, the TB program conducts these active case-finding campaigns where they go to one particular vulnerable area and screen all the people in that particular locality. So it's very important for the program to understand which areas they need to go and target, actually. So coming to all these problems related to TB, we have 4 different solutions in screening, administration, and diagnostics, and during preventive medications in TB. Actually, I'll walk you through in detail about all these solutions. And another thing about all these solutions is that we don't build any standalone solutions, like a separate app, which we put it in Play Store or App Store for the healthcare workers to use it, because already they are overburdened with multiple different apps which they use for multiple different programs. So in India, we have this national portal called Nikshay, which is the Health Management Information Platform, which is meant for all healthcare staffs and all the patients who are being even screened for TB. Presumptive TB cases also needs to be entered into that particular portal. And there is a mobile version of that particular app which is used by field workers, and they do enter that also. And another version which is available for patients, which is a self-screening, as a self-screening tool also, and also to monitor their medication. Because the government gives them nutrition schemes, like 1,000 rupees per month for their nutrition. So they can track when they are getting that particular amount into their bank account. And they can also track what kind of medication regimen they are on, actually. And they can also self-register their adherence for the doses taken, actually, so which is very important. So all these three ecosystems are Nikshay, and our solutions are integrated or being integrated to any one of these platforms, and we don't have any standalone applications. So interoperability in the field of AI is very, very important when we develop digital solutions for us. Cool. Coming to the first solution that we have under screening, it's called Coffee Against TB. So the idea for this project started back in 2019, where University of Cape Town made a project with just 150 cough samples. They were able to identify between people who have TB versus people who don't have TB. And WHO estimates that there are around 3.1 million TB cases, 31 million TB cases across the world, actually, but only 28 million are being reported, actually. Nearly 3.1 million, 3.1 million cases are being missed out. So these cases which are being missed out are primarily asymptomatic cases or partially symptomatic cases which the program neglects at the time of screening. So what we have done is that we collected cough sounds of people who are visiting the facility at the presumptive stage, and we collected their ground truth for it, their confirmatory diagnostic test for TB. We had a repository of around 100,000 people's cough data and their ground truth, and we developed a model. And this particular model is available over a smartphone, and it works in offline mode also. And the healthcare worker goes home by home and then asks the subjects to cough into that particular mobile phone, of course, by wearing a mask. And based on the cough signature, it predicts whether they have pulmonary TB or they are not at the risk of pulmonary TB. And the good part about this is that, like, one, it's currently under the Indian Council of Medical Research validation. Once the validation is over, we want to deploy this particular solution into the patient-facing app, where any common public can use it to self-screen themselves at home by just putting their cough signature into the application. This particular tool is now deployed across 16 states in India, actually, and it has an accuracy of around 92%. If anybody wants to test themselves for TB, I have the app in my mobile. Feel free to come to me and you can get yourself tested. And also to just give you an idea how the performance of the model works, what we have observed very closely is that I want to share some interesting insights. Among the confirmed TB cases who are caught by this particular application, 80% of them were caught by traditional case symptom-based screening and also by the AI. 15% were caught only by the AI. They were completely asymptomatic and partially symptomatic cases, actually. Those cases would have been missed if not for this AI intervention. And some of the learnings during the implementation of it, we missed a lot of cases at the time of data collection, and the model was not performing well during the early stage of deployment. Because at the time of coughing, people were talking, or there were too much of disturbances when we implemented this. So what we did is that we built another AI model which actually detects cough. So you can try that out. I have the application with me. So only the validated input is sent to the final model for interpretation, and then the final inference is made. So that's about the cough TB screening tool. Moving to the next one. The next tool is called line probe assay, actually. So it is one of the tests which is used to detect drug-resistant TB for first line and also for second line LPA TB drugs. Just to give an idea that there are traditional drugs, 4 different drugs, rifampicin, isomazide, pyrazinamide, so you don't have to remember this. There are after a TB patient is diagnosed, they undergo a series of tests to identify if they have drug resistance or not. If they have found out that they have drug resistance, then their medication regimen is changed and they are put into that particular treatment. So this particular test comes as a second level of test, which is used to detect few drug-resistant tests. And it's a very complex project, diagnostic test where once the sputum is collected, it is sent to the state headquarter laboratory, which is called the Culture and Drug Susceptibility Testing Lab. And the DNA is separated out from the sputum, and it is run through the different hybridization machine. And after that, the final output is a strip, actually. So if you can see over here, it has a kind of a barcode kind of thing, which has the genomic marker of that particular patient. And it is struck in a sheet. And based on different truth table logic, the presence and absence of those bands in that particular strip, they mark plus and minus, which is called genotypic interpretation. And then based on those things, they mark whether the drug is resistant or sensitive. So the problems in this test, in this particular process, is that it takes a lot of time, actually. So people have to paste it, they have to manually interpret it, and then once the interpretation is done, they need to enter the results back into the MIS, which is NICSHE. So what we did is that, like, if in case if they do the calculations wrongly, a person can be diagnosed as drug-resistant TB instead of drug-sensitive TB, and a drug-sensitive TB patient will continue drug-resistant TB cases, which will not cure them, actually. So what we did is that we collected these sheets across the country and developed a computer vision-based model, which by just taking a photo of this sheet or by just scanning this particular sheet, the bands in these particular sheet are read, and then it gets integrated into the national system, actually. And of course, there is a human in the loop concept in this particular thing. The AI just reads the bands and then shows the final output. Still, the final microbiologist or the lab technician has the ability to change the AI's output, actually. So that is very important. In any AI system, it's very important to build this human in the loop concept so that we don't replace the humans. AI is just guiding them take much faster information before processing the results. This solution was evaluated by the Indian Council of Medical Research, and it is integrated into NICSHE. So we did a before and after study of the effect of this particular intervention. Previously, the turnaround time for the line probe assay test was around 28 days, actually. Currently, it has reduced to 7 days, which is much better. The national guideline says it should be less than 14 days for better initiation of treatment. Thanks to this particular tool, we have reduced it to 7 days. And countries like Vietnam and Nepal has expressed interest to take this up into their national portal integration, where LPA is still being used as one of the tests for drug-resistant TB. Moving to the next solution, it's called prediction of adverse TB outcome. So the adverse TB outcome which we are predicting using this tool is loss to follow-up and mortality. Loss to follow-up means if a TB patient is not being found after 1 month, even when the field worker searches for them, it could be due to multiple reasons, whether the patient is been migrated from one place to another, or they have stigma and they don't want to continue the drugs, or they probably die. These could be termed as loss to follow-up. If the program is not able to trace them, it's called loss to follow-up, and mortality is a TB patient dying, actually. We started this project with just prediction of loss to follow-up. Because although loss to follow-up was just 3.5% at that point of time, it's a very important adverse outcome to be addressed. Because these are the people who have TB or who would have taken medication for TB for some time and still they're out in the community. There are two reasons. Either they could be spreading the disease, or they could end themselves being into a drug-resistant TB case, which is even more hard to detect. And drug-resistant TB also spreads much faster compared to traditional drug-sensitive TB. So it is very important to address these problems and then catch these people and give intensified interventions for them so that they don't fall out of the treatment. When we developed this tool for loss to follow-up, the WHO national program officers and the epidemiologist team suggested that why can't you combine mortality also? because loss to follow-up and mortality for TB patients, 70% of them happens within the first 1 month of treatment initiation. And the intervention package, which is being designed for both these abnormalities, are similar. So we redeveloped the model actually. So how it works is that we train this particular model from the last 7 years of historic data that we had in the national portal. And we throw a risk score based on the basic parameters that is available. Their demographic details, their HIV status, what type of test they got diagnosed to, what kind of resistant pattern they have got at the time of diagnosis. Based on all these things, we give them a risk at the time of treatment initiation. And we have designed a series of interventions to be followed up for these high-risk TB patients. Because any AI without a follow-up of intervention is useless, actually. Programmatic implementation only makes AI actually make in use in the field. So for example, if a particular patient is flagged as high risk, and if that particular person is a co-infection patient, a HIV infection patient, they have to be initiated in antiretroviral treatment within 1 week. And their CD4 count needs to be updated once a month. And the healthcare staff has to visit the patient once a week rather than once a month for a low-risk patient, actually. So the intervention package which is designed are intensified for high-risk patients so that we don't leave out the rest low-risk patients, because they are still TB patients, but they are relatively low risk, actually. And also, we deployed this particular solution across all the districts, actually, in India. Before we deployed it across all districts, we initiated this in 10 states, actually, and we did a small study and user feedback, actually. We found out that in the intervention districts compared to the control districts, the relative reduction of adverse outcome was 27%. And also, in the districts where this tool was implemented, the public health actions, like the follow-ups, et cetera, which is being updated in the Health MIS portal, has increased by 60%, actually. So now we have got the approval to get it integrated into the national platform. It's being integrated so that they don't have to directly use it in an external portal. And this particular tool is also recommended as a priority mechanism for differentiated TB care, meaning every TB patient needs to undergo a few tests, actually, like liver function test, kidney function test, et cetera. Like 21 different medical tests needs to be performed at the time of treatment initiation. Due to medical facilities and shortage of staff, not all TB patients are being able to provide that particular service. So the high-risk patients are given preference to do that differentiated TB care. So it's used as a triaging mechanism for people to use the differentiated TB care. Moving to the last solution, which is an administrative-based solution, which is called vulnerability mapping of TB. The program conducts active case finding campaign where people, like the TB program officials using a mobile van with chest X-ray and with other mechanisms, they go to a most vulnerable population, a slum area or a prison or an area where they feel that they can catch more TB cases and screen all the people in that particular locality, actually. It's a very costly affair, actually, and it's very important for the program to conduct these campaigns in right places, actually. And due to multiple different parameters, this could vary, actually. Until the solution got introduced, people used traditional methodologies. Based on historical case trends, they said that, okay, this particular area, I can catch more TB cases. So they'll go to that particular place and catch it. And not many times these are so efficient. So what we did is that we came out with a solution, a geospatial solution, where we got the coordinates of previous confirmed TB cases and other geospatial data sets, which contains socioeconomic parameters, the population density, how many water bodies are there, et cetera, a contextualized data set, and a program data set which contains how many HIV people are living in that particular community, how many people have diabetes, et cetera. So a programmatic data set. And we built a data pipeline which could plot at a tile level. A tile is a 500 into 500 meter specification in a satellite, actually. And we predicted how many cases we could get at a tile level, and then interpolated that and started giving risk prediction as low, high, and medium for a ward, which is a unit of different villages, and also at a village level. So we map the boundaries and we build this pipeline which gives you high resolution case counts at a tile level, and we map it, and we started visualizing that in the map for the administrators to conduct these active case finding campaigns. So what they do is that they go to all the red zones or the red villages where it is shown, and they go and conduct the camps over there. We deployed this particular solution across 690 districts of India where active case finding campaign was happening for a period of 4 months. What we observed is that TB detection rate has improved in a couple of states, and then people needed for screening, it's called NNS, number needed for screening to get one TB case, that has improved a lot actually. So this particular program will also be integrated into the national platform, which will help the decision makers to take appropriate decisions. And also one more thing, the screening data which we get from the cough solution, which I presented first, also feeds into the data pipeline that we have built over here. So the geotag location of the confirmed TB cases also feeds in. So the model is trained and deployed in such a manner that it gets updated every 2 weeks, actually, based on the notification rates, based on the screening rate that is being done by the field. So it's an interconnected data system that makes the solution active, and then the authorities can take appropriate discussions. So this is the final solution. So just to conclude that, it's very important to create solutions using local contextualized data and always brainstorm with the government and with the appropriate stakeholders to take up problems that could be solved by AI or any digital interventions. And then always be ready to learn from your failures, actually, because we had other solutions which failed. We developed a solution for digitizing the OPD forms and the treatment cards, etc. But due to multiple reasons, lightning or the language that is being used in the treatment cards, it couldn't pick up, actually. So it is very important to conduct user research before we deploy a solution at a national level or even at a county level. Thank you.